Hello everyone. Today we'll be talking about chest X-ray cases. So basically what you need to know about this video is this is not an introduction on how to read the chest X-ray. There is another video that I've uploaded that talks more on the introduction on how to read a chest X-ray. So in this video we'll just be talking about a few common cases such as pneumonia, tuberculosis, pneumothorax, and such other cases. So I would suggest if you want to just refresh your memory, you can go to the other video first and then come to this one. However, if you're currently practicing, you can just start with this video. So basically this is a diagram showing a normal chest x-ray. So there are a few things I'd like you guys to note is the number of ribs that you're able to see, the number of posterior ribs. 1, 2, 3, 4, 5, 6, 7, 8. So there should be at least 8 ribs that you should be able to visualize in full inspiration. You should be able to see the trachea, the tracheal bifurcation, the aortic arc. Then one very important thing is the costophrenic angles. I hope you're able to see how sharp they are. Yes. Then the right atrium border, the heart, the left atrium border, the pulmonary markings. Yes, so the things that I've mentioned are actually very important, so please take note of them. Let's move. So let's talk about some common alveolar patterns. So one thing you need to take note is the type and homogeneity of the opacity. So what does that mean? So if you look at a normal chest x-ray, you're going to see that the opacities are usually homogeneous. They're actually similar, like you can see the same pattern on both lungs. So that's what is the type and homogeneity of the opacity. Then to the silhouette sign. So what's that? So that's basically seeing the outline of tissues. So this is the silhouette sign, the cardiac silhouette. This is the right border. This is the left. So this is what the silhouette sign is. So you'll notice in some lung pathologies, the silhouette sign will be obliterated. And now we'll talk about air bronchograms. So what are air bronchograms? So usually if we look at the lung, we know that the lung is filled with air, right? The alveoli are filled with air. Then we also have bronchi that also have air in them. So due to which you are not usually able to appreciate the bronchus because the bronchus have air and the alveoli around them also have air. So what are air bronchograms? So these are basically the ability to see the bronchi when the surrounding alveoli are filled with fluid, such as edema or pus, but the bronchi remain clear filled with air. So that's what a air bronchogram is. I think we'll be able to appreciate that in one of our images. So yes, basically the conditions we'll be talking about will be pneumonia, pulmonary tuberculosis, pneumothorax, pleural effusion, and atelectasis. Okay, so sorry, this slide was supposed to come before, but let's talk about it. Then the same we talked about alveolar patterns, there are also interstitial patterns. So there's linear, miliary, reticular nodular, honeycomb, and nodular. So linear pattern is seen as curly A, B, and C lines. Curly B lines are normally seen in congestive cardiac failure, interstitial pulmonary edema, lymphangitis, carcinomatosis. Miliary pattern is seen in TB. Reticular nodule is seen in TB, silicosis, rheumatoid lung disease. Honeycomb patterns are seen in fibrosing alveolitis, bronchiectasis, and nodular patterns are seen in tuberculosis, pulmonary edema, sarcoidosis. So the first condition we'll start with is pneumonia. So what is pneumonia? Pneumonia includes an inflammatory condition of the lung parenchyma in which some or all of the alveoli are filled with exudate, which is basically fluid and blood cells. So pneumonia is classified into lobar pneumonia and bronchopneumonia. So what are the common radiological findings in lobar pneumonia? So you are going to see homogeneous lung opacification, which is limited by fissures. The affected lobe of the lung retains its volume. And one thing you need to take note is in children, occasionally you may see rounded consolidation with ill-defined margins. So you're going to see round cavities. So sometimes a person might start suspecting that this may be a cancer, but no. So once you give them antibiotics, so there's spontaneous resolution. Then it often shows air bronchograms. Cavitation is very unlikely, however, it may be present. Pneumonic effusions are fairly common and empyema not so frequently. So let's look at the X-ray. So one thing we need to take note is, are you able to see the homogeneous opacifications? Yes, so immediately you see that you can already start thinking of pneumonia. And you're able to see that the affected lobe, it has still retained its volume. So this is why I said that in children sometimes you may see a rounded mass maybe here, which a person might start suspecting it's cancer, but it's not. That's how sometimes it may present in children. Then often shows air bronchograms. In this image it's not so clear, but I'll show you in the next image. So basically if they ask you what do you see, what are the common patterns, so you should be able to see homogeneous opacifications that are limited by fishes, okay? Then you can also put the often show air bronchograms, and you can put that cavitation is very unlikely, however it may be present. So yeah, so let's look at this pneumonia. So this left upper lobe consolidation, there's density in the left upper lung field, there's loss of ciliate and left heart margin. I hope you're able to see there's no left heart margin here, there's no ciliate sign. Then there's density in the projection of the left upper lobe. Sorry, I forgot to put that image here. And you should be able to see air bronchograms. Yeah, these are air bronchograms, very clear. So normally we're not able to see them because even the lung is filled with air. But here, so I hope you've appreciated the air bronchograms. Then let's look at radiographic findings of bronchopneumonia. So you see heterogeneous opacities in a scattered multifocal and bilateral. If you remember in global pneumonia, we said that they're homogeneous opacities. In bronchopneumonia, they're heterogeneous opacities. And they ask in a scattered multifocal and bilateral distribution. However, one thing you need to note is with worsening of disease, opacities may become more homogeneous. Air bronchograms are usually absent, and pleural effusion or empyema, cavitation, pneumothorax, and atlelectasis, they're all very common in bronchopneumonia. So let's look at the diagram here. So first thing you need to take note is the heterogeneous opacities here. Are you able to see this? Yeah. So these are heterogeneous opacities, and you can notice that they're present bilaterally. Then you're unable to appreciate any air bronchogram here. And then one thing we said is that with pleural effusion or empyema, cavitation, pneumothorax, and atelectasis are common. So you shouldn't be surprised if you see a bronchopneumonia as well as a pleural effusion. Okay. Then one thing you need to know is pneumonia caused by Staphylococcus is quite common in children, and in those cases, you may be able to notice pneumatocysts. So, what are pneumatocysts? These are basically air-filled pockets, air-filled cavities that may be present more commonly in children. So, that's all about bronchopneumonia. Let's go to TB. So, TB is an infectious disease usually caused by Mycobacterium tuberculosis. It commonly affects the lungs. So what is the radiographic pattern? So you're going to see hilar and mediastinal lymphadenopathy with or without pneumonia. Adenopathy may cause tracheobronchial airway compression leading to segmental or lobar collapse, especially of the medial lobe. So these are pneumonic consolidations. So basically the consolidation that starts off on the lung, that's the gone focus. Then we know that this lymphadenopathy commonly, so a gone focus plus lymphadenopathy leads to a gone complex. Then, if the gone complex calcifies, then we then call it Ranke complex. And cavitation is rare in primary TB. You need to take note of this. Cavitation is very common. It's actually the hallmark of post-primary TB, but it's rare in primary tuberculosis. Then one thing you need to know is primary TB may also present as empyema, pleural effusion, miliary shadowing, spontaneous bronchopleural fistula with hydropneumothorax or pericardial effusion. So let's look at the diagram here. So I hope you're able to see adenopathy here, here. Then this is basically a gone complex. So remember what a gone complex was? That was gone focus plus lymphadenopathy. Then if we talk about post-primary TB, so the radiographic pattern, there'll be patchy bronchopneumonia. Usually the consolidation is restricted inside, commonly occurring in the upper lobes or apical segments of the lower lobes. However, there may be bronchopneumonia spread and nodular shadowing occurring anywhere in the lungs. Cavitation is common and a hallmark of the disease. Usually there is no adenopathy, so remember in primary we usually have adenopathy and rarely cavitations. However, in post-primary cavitations are common and adenopathy is not really there. There may be volume loss and fibrosis occurring along with cavitation, may present as an effusion or empyema in young adults or pneumothorax due to a ruptured focus. Miliary shadowing, so that's basically discrete 1 to 2 millimeters nodule distributed evenly throughout the lungs. Then you also need to take notice as healing progresses, features which may be recognized are fibrosis and volume loss shrinkage, may be calcified foci, tuberculoma, which is a localized granuloma, often containing calcification and pleural calcification. So let's discuss this diagram. This chest X-ray showing post-primary TB. So one thing that I really wanted you guys to take note is the patchy bronchopneumonia. Are you able to see this? Patchy consolidations. Yes, and the other important thing I want to show you is the cavitations. So if you're able to appreciate there's a cavity here, then there's another cavity here, and another one on top. So remember cavitation is common in post-primary TB. So once you look at a chest X-ray and you notice this cavitation, you automatically think that this is what post-primary TB. So we now move on to pleural effusion. Pleural effusions are collections of fluid within the pleural space. So what are the radiological findings under pleural effusion? So the first sign is blunting of the normally acute costophrenic angle. Remember I showed you in the first X-ray, the costophrenic angle. Then larger collection shows as homogeneous opacity devoid of lung markings. So you need to take note of this. Remember in the first X-ray I showed you there were lung markings, then there was an acute costophrenic angle, so this will be absent. Concave upper body higher laterally than medially. Then there will be loss of diaphragm, loss of the silhouette sign. Massive effusions cause underlying lung to retract to the hilum. I don't know if I'll be able to show you this, but let's hope so. Massive effusion cause complete opacity of the hemithorax and mediastinal shift. If lung completely collapses, there may be no shift. So let's see. So let's look at the diagram. Are you able to see the concave border? You can see that there's loss of lung markings. There are lung markings on this side, however, on the left side, there are no lung markings. There's loss of the left cardiac border. There's blunting of the costophrenic angle. So immediately you see this, be like, this is pleural effusion. Then another thing is you're able to see the mediastinum and the trachea have actually moved to the contralateral side. Take note of the trachea. So these are some of the important findings under pleural effusion. So massive pleural effusion. So unilateral homogeneous density, mediastinal shift to the right, are you able to see? Even the trachea have moved to the right. Left diaphragmatic and left heart silhouettes are lost. And then the left hemithorax is larger. Are you able to see? Yep, it's way larger than the right. So we can now move on to pneumothorax. So this is basically accumulation of air within the pleural cavity. This occurs when air enters the pleural cavity through a chain, either the parietal or visceral pleura. The lung subsequently relaxes and retracts to a varying extent towards the hilum. So what are the radiological findings? So there will be absent lung markings between the lung edge and the chest wall. There will be increased translucency of the affected hemithorax. Air rises, so a pneumothorax will usually be seen largest at the apex. The lung edge becomes visible as the lung retracts towards the hila as it is displaced from the chest wall. Visceral pleura shows as a thin white line. Air rises due to the gravity, so a pneumothorax will usually be largest at the apex. So if you'll see a pneumothorax, most likely it's going to be seen at the apex. And if you look at a pleural effusion, most likely it will be seen at the bottom because of gravity effects. Then the mediastinal displacement with depression of the diaphragm if tension develops. So you can read a bit on tension pneumothorax. So let's look at this diagram. So the first thing that you can start appreciating is this absence of lung markings. You're able to see them here, the vascular markings. Here you're unable to see them, so you already start suspecting pneumothorax. And you're able to say the pneumothorax is on the apical area. And then there's increased translucency of the affected hemithorax. Then yes, so I don't know, let's see if I can show you the lung. So this is the lung here. So basically that's all that you're able to appreciate on this image. I wish I'd put the other image that showed the visceral pleura, but it's not here. So basically we're able to appreciate that this is more this increased translucency, this absence of vascular markings, and the pneumothorax is on the apical region. So attention pneumothorax, this is the one that you do not miss, and it's a medical emergency, so you need to know how to read this. So if you cannot diagnose attention pneumothorax at medical finals, you won't find an examiner who will defend you. This is that important. Then the left hemithorax is black due to air in the pleural cavity. So what are the signs of tension? The left lung is completely compressed, as you can see on the arrowheads. Yeah, this is the lung here. The trachea is pushed to the right. Hope you can notice that. The heart is shifted to the contralateral side. You're able to see that as well. And the left hemidiaphragm is depressed. Are you able to see here? Yes. And if you're able to diagnose a tension pneumothorax clinically, as you know that thing, tension pneumothorax has very prominent clinical findings. Sometimes you may not even need an X-ray and you'll be able to detect it. So you need to relieve the pressure immediately. 5. Atelectasis. So atelectasis is basically a complete or partial collapse of the entire lung or a lobe of the lung. It occurs when the tiny air sacs, the alveoli within the lung, become deflated or possibly filled with alveolar fluid. So what are the signs of lung collapse? So if you look at a whole lung collapse, there will be a complete opacity of the hemithorax, displacement of the mediastinum to the side of the opacity. So if you remember when we talked about pneumothorax, displacement is to the opposite side. In collapse, it's displacement to the affected side. Ciliate sign will be lost, loss of diaphragm and mediastinal outlines, herniation of the unaffected lung across the midline. So let's look at this. So you're able to notice this complete opacification of the left hemithorax, able to see the mediastinum and the contents including the trachea have displaced to which side? To the affected side. There's absence of any lung markings. So basically if you look at this, everything is done. We saw there's complete opacity, we saw there's displacement of the mediastinum, silhouette sign with loss of diaphragm and mediastinal outlines. You're able to notice that. There is loss of right cardiac border, then herniation of the unaffected lung across the midline. Are you able to see that this is moving slightly towards the left side? So what are the signs of lobar collapse? Increased density due to loss of aeration, crowding of the blood vessels, displacement of the hilum upwards or downwards, displacement of a fissure which may be bowed, shifts of the mediastinum trachea towards the collapsed part of the lung, elevation of the diaphragm ciliate sign. The remainder of the lung may be overexpanded and hypertranslucent with fewer vessels showing, and rib crowding may occur in children or with long-standing collapse. So if you look at this is a what? Right upper lobe collapse. Able to see there is absence of vascular markings, there is bowing of the fissure. Then I don't know if you're able to see the trachea has moved to the affected side. So basically that's all about lobar collapse. So atelectasis of the right lung, homogeneous density in the right hemithorax Mediastinal shift to the right, right hemithorax is larger, right heart and diaphragmatic silhouette are not identifiable. So self-assessment, before that I'll just like to give a brief summary here. So this is tumor infiltration, this is atelectasis, which is left lower lobe collapse, cardiomegaly, you're able to see the cardiothoracic region is way larger. Then this is effusion, pneumothorax, pneumonia, a nodule, and a mass in the lung. So let's look at this. So I'll give you 10 seconds to try and answer. Or you can pause the video and try to find the answer and then we can move on. Okay, I think that's it. So this is post-primary tuberculosis. I hope you were able to see the cavities here. This cavity and this cavity, and immediately you see cavitation, you automatically think of what? Post-primary TB. Then this is the second image. You can pause, come up with the answer and then play. So this is pleural effusion. I hope you're able to see blunting of the costophrenic angle, absence of markings, the diaphragm, right hemidiaphragm, you're unable to see that. Then on the right cardiac body, you're unable to appreciate that too. Next image. This one is very easy. I hope you get the answer. You can pause. Okay. So this is lobar pneumonia. On this one, I didn't even have to say anything. You're automatically able to see the homogeneous consolidations. You're able to see the A bronchograms. Then this one. Okay. So what is going to give you a good idea is, whatever is here is massive. So it could be a massive pleural effusion, it could be a total right lung collapse, right? So what's going to tell us what it is? It's the trachea. So if the trachea has moved to the affected side, what is the answer? If it moves to the opposite side, what is the answer? I hope you know that. So this is right lung collapse. As we know that in right lung collapse, the trachea is going to move to the affected side, and in pleural effusion, massive pleural effusion, it moves to the opposite side. So basically that's all. I think they were 4 self-assessment questions. If you got 3 out of 4, very good. If you did not, don't worry, you can watch the video again and still attempt as many times as you like. So if you like the video, please subscribe, like, and comment. And comment on how many answers you managed to get right. Thank you.